talk way more.
Yeah.
We can talk for hours. So that's going to be kind of the goal, but I feel like we can do many of these. So.
Sure. I'll come back if you'll have me.
Perfect.
Really great mastermind as well.
Yeah, we did.
And don't worry, I gave our group a name. It's the Chatta Mastermind Group.
Oh, thank you for putting Chatta in front of it, because you Chatta, I mean, yeah.
And this is my way to come up with names.
I love it. Okay, well, I have yet to officially record an introduction for this podcast, but actually this is quite full circle, because I tried to launch a podcast in December, but it wasn't really a podcast. It was a mastermind series on lives on Instagram, and we know how social media is. Anyway, that was its own journey, and you were the first person that was on that. So here we are actually officially recording our first podcast. So welcome, Jason. I'm really excited to be here.
Love it. Thanks for having me back.
Yeah, and so this is like, I really want this whole podcast, I want this to be a conversation, because we can talk for hours about all of the different things.
Right.
And I think for a long time, I was like, okay, we have to have a certain structure, we have to have these certain topics to talk about. And honestly, the most fun conversations that I have, and the ones that I love to listen to as well, are the ones that are just free flowing. So
Totally.
That is why we're here. But in order to give people a little bit of background, because I have background, but you don't, or they don't on you, give the people a little bit of a background on who you are, what you do, and yeah, what brings you into the human health collective sphere as we are creating it.
Thanks for narrowing that down, because I was going to give some sarcastic, I'm a human being living on planet Earth. So my name is Jason Therrien. I am a doctor of physical therapy. I specialize in treating people with persistent or chronic pain conditions. I also have experience as a coach, so I integrate that into how I work with people. I have a passion for helping people understand the nature of their health conditions and the overlay of suffering that comes with that. That might be a fun thing to unpack a bit.
Yeah.
So I have a kind of different, kind of a unique way of putting things together and how I work and interact with people. I'm trying to get some new things off the ground to help reach more people through classes and programs, some live, some pre-recorded, self-paced kind of stuff. And yeah, that's a little bit about me.
Yeah, it's amazing. So I know we met probably, maybe it was a year or so ago. Honestly, I think it probably was around a year ago, maybe slightly more, when we first sat down to have coffee, and we talked for 2 hours. But I honestly kind of forget, so you're gonna have to remind me, what actually brought you into the chronic pain field? Because it's a bit of a niche. I think all physical therapists, all doctors should be more well-versed in it, but it's definitely an expanding field, and not a ton of people know a lot about it. So what was the roundabout way that you got to where you are with that?
Yeah, so I'll try to do the Cliff Notes version of that story. Going into college, I thought I was going to be a therapist, like a psychologist. I was disabused of that notion and decided to go in a different direction. So with my sports background and a desire to help people through tough times, kind of an idea, physical therapy made a lot of sense. So I started my movement in that direction. Along the way, I started working with people in a program in a YMCA in Augusta, Georgia called the Adapted Aquatics Program. And really quickly, my focus as I was approaching physical therapy school became less about sports and orthopedic musculoskeletal kind of rehabilitation and more towards really helping people with really challenging health conditions, like people who've born with things like cerebral palsy or acquire things like strokes or Parkinson's disease. So helping people with really debilitating conditions became just a natural fit for me. So when I went into PT school, I thought that my focus was going to be, when I graduated, in the neuro field. So I've always thought number one, helping people who really are suffering and need that compassionate care as they navigate the new realities of their life. And two, the nervous system is so interesting. Once I learned about neuroplasticity and how our brains and nervous systems can be rewired out, I was totally in. So I graduated PT school, and I started off in skilled nursing because the opportunity wasn't quite there for something more like a inpatient neuro rehabilitation, like a inpatient hospital. But I was still able to work with a similar kind of population there. So anyways, I do that for a while, and then for reasons that are less important, I decided to try something different. And when I did, I moved from the skilled nursing subacute care into outpatient orthopedics. And I realized really quickly how bad I was at helping people. Helping people with persistent pain, that is. So people with chronic back pain, or neck pain, or knee pain, or shoulder pain. What I mean by bad at it is I didn't feel like I had some really great mentors around me. There's a lot of techniques that I learned in terms of manual techniques and exercise prescription. But there were just some things that were peculiar about helping somebody with chronic back pain for someone who is rehabilitating a shoulder surgery or a recent ankle sprain. There's just something different, and I wanted to understand that better. And then kind of out of the blue, something fell on my lap, which was a video by a guy named Lorimer Moseley. Some people in the pain science sphere would know that name. He's kind of a rock star in terms of pain neuroscience, both from
it's a cool thing to be a rock star.
Yeah, for sure. Yeah, he's on the Mount Rushmore of pain science rehabilitation professionals.
Nice.
So anyways, when I watched his TED Talk about pain and how it's way different, how it actually works is way different than anything that I had learned in PT school, and I graduated in 2011. I realized really quickly that the field of pain science ties in all those other elements that I mentioned earlier, the psychology, the nervous system, helping people navigate how to work with the suffering that they're experiencing, both from the condition, but also the secondary effects of the condition, the way it affects their physical life, their functional life, their emotional life. And from that point on, so this is about 2015, 2016, I just decided to commit all of my energy and resources to becoming a pain specialist, which I think is kind of all ongoing work. I mean, I don't think there's ever a stopping point to specialize.
For anything, really. I mean, I think with any specialty, you're going in and you're like learning, and I mean, there's so much constantly new information coming out, which is so cool because it means that people are discovering new things and new methods and everything, and that's really cool. Like I had forgotten the kind of journey that you had to get to where you are, and it's so cool to hear how personal experiences and all of these different pieces of the puzzle come together, because I mean, I think that was the same for me. It's, you go down one path and it's like, oh, I think I'm gonna pivot now, and then it's, oh, I'll maybe pivot a little bit, but the underlying, help that you wanted to provide people kind of came full circle then from the mental health side of things and all of that. And I don't know, I mean, I'm curious to hear a little bit about what maybe your pain science was in PT school, and then what you actually were learning in those additional courses and everything that you were taking outside. Because for me, we learned the map, so if for people who don't know, it's kind of, the baseline, you get hit by something or you step on a nail and then your pain spikes up, it passes the alarm bell, your alarms, and then with chronic pain, you kind of end up at this higher level frequency where your alarm bell is closer and closer, so you kind of hit that alarm bell more. And that's the basic framework that we learned, and it was pretty decent way to explain it to patients. And I'm probably not even doing it justice, but at the very rudimentary level. But for you, when you're talking to people about explaining pain science, because I think it's such a difficult topic sometimes for people to get into, because there's a lot of emotional components, there's so many different layers to it. How do you kind of go about helping people learn what pain actually is? How do you define pain? Because there's so much to it.
Yeah, so I feel like there's two questions there.
Yeah, there's probably a lot of questions.
One question is, how is what I learned different than how is what I was trained in PT school different than what I learned later? And then how does that shape how I work with patients and how I empower them, or attempt to empower them through better understanding or insight?
Yeah.
Well, I'll start with the first, because this is where my nerdiness can come out in a conversation with a physical therapist or another healthcare professional. Yeah, don't get me started. We can have this conversation all day about the science, the philosophy, all that. And then I'll try to keep that brief, and we'll talk a little bit about how I've learned to just speak briefly to the second question, like how does that shape what I do with people who suffer with it?
Right.
There was a quote a long time ago, and I can't remember exactly who it was. I think it was Sandy Hilton. She said, "Pain science isn't something you do; it's a way you practice." So it's like you're not doing pain science; it just informs how you practice. Right. So, anyways,
that makes a lot of sense.
Yeah. So to kind of to be honest, like when I was in physical therapy school, my focus was not on, I can't wait to graduate and become an outpatient orthopedic physical therapist.
Yeah.
No offense to anybody, that's the majority of our profession is in that field or in that realm. So my focus wasn't really on musculoskeletal rehabilitation. I was more interested in the neuro class or the cardiac stuff. Subacute rehabilitation was always really interesting. But anyways, what I remember is that basically, as far as pain science goes, you have certain fibers, certain nerve fibers, nerve types in your body, and that we have some that are, back then, if I'm not mistaken, we call them nociceptive fibers, but they were very interchangeably called pain fibers or pain nerves or pain signals that would come from the body. Right. So just on that point, that's not how it works. That's one of the first things that I learned in the pain science training and the pain specialty training is that pain doesn't come from our tissues. What we have is nociception, and nociception is the detection of disturbances, typically with like inflammation can increase nociception. Mechanical stress to a tissue can cause nociception, but the urge to empty your bladder, for example, is nociception. So it activates what are called C fibers, and that is, unless you have a UTI, probably not painful. Right. So nociception is basically, if you want to reframe that as danger signals, or a threat is arising. Yeah. Pain doesn't come from our body parts that hurt. This is more fun to talk about with a clinician.
No, I think it's so cool though, because I think this is interesting for people to understand about this. And well, I don't know, maybe it is or maybe it isn't. For me, it's incredibly interesting. But because even if somebody doesn't understand every single thing that you're talking about, C fibers, whatever, to understand that there's actually something else that's going on is so important. So keep going, I'm curious, keep going.
Cool. So yeah, what actually happens, at least my best understanding, because I'm not a neuroscientist myself, but I've been trained to integrate that into how I approach things like persistent pain conditions. Well, basically your body sends the brain signals, and this is the same thing with vision or any other experience that we have. So let's just use vision for example. You don't have vision receptors in your eyes. You have light receptors. Right. It's your brain that creates the experience of vision. And one way to validate that really quickly is to say, have you ever had a dream?
Yeah.
Sure. Did you see stuff? Yeah. Were your eyes open? No.
That's so true.
Your brain creates the experience of vision. Your eyes can only send light information, but your brain creates vision. Your ears can only send vibration information. Yeah. It's your brain that creates the experience of sound. Yeah. That's why you can get a song stuck in your head. Yeah. Same thing with sensation. Your body sends information, your brain determines how to present that to you through the experience of sensation. So it sends sensory information, your brain creates the experience of sensation. Right. So for example, if you sprain your ankle, you're going to have those danger signals coming up, that nociceptive stimulation. Right. Your brain will then analyze that and say, okay, you need to know about this and produce ankle pain so that you can take care of the problem. But if you sprain your ankle and you're crossing the street and a bus is flying at you, your brain's probably not going to produce ankle pain.
Yeah.
It's going to get you the heck out of the way of the bus, right? So
Yeah.
you might jump out of the way of the bus and not experience any ankle pain until the coast is clear. It doesn't mean that you didn't have the danger signals coming, and it doesn't mean there was no damage. It just means that pain and damage are not the same thing.
Yeah.
So that's one of many layers of new understanding that's nuanced and important for me as the clinician, maybe not always for the person who's experiencing pain. So we can talk a little bit about some of my trials and tribulations of educating patients about pain, and how sometimes what I think is interesting and exciting and important isn't as interesting, or ultimately isn't as helpful to the person across from me. They don't need to know all that I just shared, although I tried at times to maybe push that message a bit too often. So that's one of the things.
You're excited about it, which is
so
great.
Excited, yeah. So that's one of the things that I've learned, is that pain doesn't come from the body, and I think that's a really important thing that we understand as clinicians, because it actually, one of the other really cool things on a more philosophical, I guess, or I guess ideological perspective is the notion that if you have ankle pain, that your ankle is telling you that it hurts. That idea is really, really old. It goes back to Rene Descartes. People may have heard, most people have heard the expression, I think, therefore I am. That's another thing we attribute to Rene Descartes. And he was a really important person in the development of the concepts and ideas and philosophies that exist today. But like any person, they had blind spots. They didn't fully understand the picture because they didn't have the science. So the point there is, Rene Descartes set us up for what we still today practice, which is, if you have ankle pain, the property of pain, the experience of pain exists in the ankle, and your ankle tells you about it. That's how most of us still operate, including those in the healthcare system, including people who are responsible for determining if you need surgery or something like that, for example. But when we understand that that's not how it works, that you can have, for example, degenerative discs in your spine and no pain, we would oftentimes classify that as damage or abnormality, but we know that there are very high percentages of people walking around every day with degenerative discs and bulging discs and have no pain. But the hard part for folks to experience pain is they see a provider, and I'm not going to name any specific professions unless we get down the road, and they learn that they have all these damaged tissues in the areas that hurt, and then there's automatically this association that now I've got this vulnerable and unsafe part of my body.
Right.
But that's not the whole picture. So what I don't try to do is saying that, I don't try to say that your degenerative changes, your arthritis, etc., are unrelated or irrelevant. I just try to say it's not the whole picture. There's a lot more going on here, and it has to do with your nervous system. It has to do with your general health profile. Are you getting good sleep? Are you eating well? And then I'm dancing around the big one, which is stress and emotion have a big part to play on what makes our bodies more sensitive and what causes things to go from acutely painful to chronically painful.
Yeah, that is so interesting, and I mean, when you say it automatically, I'm like, oh yeah, of course, I dream, I see that, and I love that way to explain it to people, because it's a very real, like, some people might listen to you as a pain specialty physical therapist, or this podcast or whatever, and not be experiencing chronic pain. But everybody has had a dream at some point, or had a song stuck in their head. And so that's such a relatable way to explain it to people, especially to people who may be adjunct, kind of, or alongside people who have chronic pain. So for the spouse who is dealing with the person who has had chronic pain, and giving a better understanding to not just the people who actually are experiencing the chronic pain, but the people who are alongside them and next to them through that journey, because that's a whole other different component. And it's super interesting. I do remember learning about the stress and the way that say cortisol levels, if you increase cortisol levels, and we need cortisol, it's a really important hormone.
Steroid.
But yeah, we have to have that. But having elevated levels above, certain threshold for each person, increases sensitivity to those nociceptive nerves. So I remember learning that, people say that, but I never had the science to back it up. And at least for me, I mean, anybody who knows me, I am very much like, I like the science. I like to have the analytical brain. I want to know. So what you're explaining to me, I'm like, this is great. Like, I need to have all of the background information. I'm like, okay, yes, now that makes complete sense.
Yeah.
But I'm curious for the people who aren't that, like, because you said some people they're probably zoning out. They're like, what the heck are they talking about? These
C-fibers?
What the heck is that? Like, how do you go about maybe explaining it to the type of person that isn't super receptive to the scientific explanations that, we like to dig our teeth into?
Yeah, so I've learned through trial and lots of error.
Mm-hmm.
What are the important things for people to start to understand that gives them a clarity as to the full picture or the comprehensive understanding of why they hurt? And comprehensive would even to an extent be inaccurate, because there are certain things about our pain that will always be somewhat ambiguous, in my opinion. So just giving them a clearer picture of what's going on in their body in a way that's empowering, so actionable, and helps de-escalate the level of threat. Or in other words, reduces fear.
Right.
Those are the key pieces. What's going to be most important there? And understanding C-fibers is not necessarily one of them. Although, since this is
for some people, maybe.
Yeah.
For others, maybe not.
That's true, depending on the personality type. And
My mom would love to know about the C-fibers. My dad probably would be like, what do I gotta do?
Tell me
Yeah.
I know that I have a client right now who's in IT, and she just loves all the education, loves all the knowledge part. As long as we get to moving to,
right.
Like it's fun to.
Let's dive in.
I love it's fun working with people like that. Like one side example, because I just love this conversation.
Yeah.
It's one of those over drinks. Sometimes it's fun to have. About the if the tree falls in the forest, does it make a sound?
Right.
To go back to your ears, don't hear things. Your ears collect vibration information. It's your brain that produces the experience of sound.
Right.
So there actually is a technical correct answer to that question.
Ooh, okay.
If a tree falls in the forest and there's no one there to hear it, does it make a sound? And people are going to yell at the speaker when they hear this, but it doesn't make a sound. It creates vibration waves, which we call sound waves. But that's like calling pain signals from nociceptive signals pain signals.
Right.
It's not sound yet, because there's no experience of sound to be had. You don't capture sound out of the air.
Right.
Your brain interprets the vibration signals coming to your ear and then creates the experience of sound. So if there is no one there to hear it, it does not make a sound. It creates vibration waves.
All right, people, we have an answer.
Feel free to push back, but I will.
You're gonna stand firm on that one.
I might die on this hill. But, anyway, so that's
great. No, that's such a perfect example of that.
Yes, your brain is what creates your experience, and it creates your experience based off of the external world and what's happening in your body.
Right.
But it doesn't come from the body. I think about like a projector. It's like if you have ankle pain because you sprained your ankle, it's your brain creating that experience in your ankle, which is why you can have phantom foot pain if you have your foot removed.
Yeah.
That's the experience of your brain producing sensation in a body part that's no longer there. There's no signals coming from that body part anymore, but the brain can still produce sensation there. So anyways, I can go on and on. But what's important for people to hear? Well, I think one of my favorite things to share is, there's a couple. Number one, let's start with pain is gray. And that's, I think, one of my favorite ones to start with, because there's this notion that if they can just find the thing that's wrong, or I can fix my posture, get the surgery, take the right supplements, whatever it may be, that if I can fix that one thing, cause and effect, like a car, it's like, well, my tires
starter's out.
Literally true.
Literally my starter's out.
Yeah. But we're not cars. We're not cars. I don't care how many metaphors that your orthopedist will give you about it. You are not a car. It's not how it works. Pain is a gray picture. It's not black or white. And that's another way of saying that there are always multiple contributing factors to our pain experience. So if we can start there, and the easy example that I use for that is, if I came to your house every night, so say you come because you've been referred for neck pain.
Yeah.
And it could be because you had a recent injury or you've had it for years. It doesn't really matter. If you have neck pain and I came to your house every night and on the hour I blew a foghorn and I did that for a week, your sleep would be totally disrupted, right? And if I was able to get away with it, of course.
Well, joke's on you because I live by a train, so.
So maybe you need like a white noise machine.
Yeah, maybe.
But the point here is, for many who have, especially with persistent pain, if you go through a period of time when sleep levels go down, both in quality and or quantity, you'll notice in most cases your pain intensity will go up. Yeah. What does sleep have to do with discs or arthritis? And the answer is nothing. It doesn't. You can make the claim that, well, if you don't sleep well, there might be more inflammation in the joint might cause more pain, and that's part of the picture. But the point there is to say, it can't be a cause and effect relationship if something like sleep can also affect how much you hurt. Right. So then we start with that, and I don't spend a ton of time anymore on sleep. Sleep's always an important area to address, so important. But the area that I love to start with is tension. So so there's lots of metaphors. Like if we have time, or if you're interested.
You're just gonna start rattling off metaphors. I love it. I'm here for the metaphor.
Well, let's start with one of my favorite first ones to introduce, and probably one of the ones that I think I just don't understand why it's not more of a centerpiece of our education. Maybe I'm not seeing my blind spots, but here's the idea: it's the fist. If you sprain that ankle, like I mentioned before, what will automatically happen is that your brain is going to want to protect your ankle. And how's it going to do that? It's going to do that typically in two ways. One, temporarily the ankle is going to be more sensitive. And that's your alarm. You mentioned that earlier. Your alarm is going to be more sensitive for a period of time, so that you don't put too much pressure on it and disrupt the healing or make it worse. But in addition, you're going to guard. And you don't have to think about it. Your brain will automatically, you can add to that by limping a bit more, being more consciously protective, but most of it's unconscious protection. Your brain tells your muscles, because muscles don't contract themselves. That's another big thing. I don't know about you, but the expression muscle memory drives me nuts.
Interesting. Okay, yeah.
Muscles can't remember.
That's true.
It's motor memory.
Motor memory.
It's motor memory. It's it's so. This is one of my pet peeves.
People are like, what's the difference?
Muscles cannot remember. It's your brain that remembers. So it's like riding a bike.
Right.
The program for riding a bike does not exist in your legs. It exists in your brain. Yeah. So anyway, I think it's important. So anyways, you have these protective motor patterns, like bracing at the hip. So for a period of time, you're going to limp and maybe guard. But what happens with ankle injuries or any injury? It heals. Yeah. And as the healing occurs, the inflammation and swelling subsides, and as the alarm sensitivity goes down and the pain intensity goes down, the amount of guarding and protection will also go down. And then eventually you go back to walking symmetrically. Right. But what happens when you have persistent pain? You get persistent guarding. Yeah. And that's what I call the fist. So then the next question is, well, if you walked around making a fist all day, how would your hand feel?
Yeah, not great.
Not great.
It really would not feel great.
It's going to feel tired. It's going to feel weak. It's going to feel stiff. It's going to hurt. Yeah. All descriptions that people who live with persistent pain typically experience. Right. So that's one of the first layers of gray that we want to focus on. Can you learn to go from this to this? And for those who can't see that, can you learn from making a fist to unclenching the fist, which isn't opening the hand, it's letting go of the tension, letting go of the guard, relaxing. And I don't mean just relax, it's going to be okay. It's like literally the opposite of contract is to relax a muscle. So learning how to relax your muscles is a huge part. And what's so wild is I spent, and I'm going back to that time period when I entered into the orthopedic world, but I felt like I wasn't well equipped to do so. Right. I did so much manual stretching. Yeah. And then the person comes back, I stretch their hip flexor, and I'm getting into it and doing what they can tolerate, and they come back and it's just as tight. Yep. Now, some people do respond to that and eventually feel better, and we can talk about why some people respond better than others. That's another conversation. But why in the heck didn't it stay lengthened? Why didn't it stretch out?
Yeah.
It's because, well, first, we don't understand stretching a lot
Right.
of times as PTs. I don't think we're fully educated that it's more of a neurophysiologic phenomenon than it is a mechanical phenomenon. But that's not as important. The point is, stretching is like taking that fist and prying the hand open.
Yeah. Yep.
What's going to happen is it's going to feel good. A lot of times it's like scratching an itch.
Yeah.
What happens when you begin scratching an itch is you get itchy. It gets itchy again.
Yeah.
Analogously, if that's a word, is analogously a word?
If not, you just made it up. I think it's great. It makes total sense.
So
I'm here for it.
Thank you. Then prying the hand open is stretching, but then it tightens back up again.
Yeah.
Because it didn't teach the brain that it's safe to unclench the fist.
Right.
So learning how to relax isn't just about taking pressure off the system, which I think is part of why it feels better a lot of times. When I teach people how to relax their body through manual techniques, for example, so instead of stretching, which I used to do a lot of, I help people realize as I'm moving and manipulating their body parts where they're not letting go.
Right.
So it becomes, number one, more about learning how to relax.
Right.
And two, this is the important part because it's like, my website called Insight Empowers. That empowerment part is important.
Yeah.
I can't make a person relax.
Right.
I can guide their attention and I can wiggle their leg around, but they have to let go.
Yeah.
And that's what they take home with them. They can't take my hands on them, but they can take that. So teaching people how to unclench the fist and relax their body is a really important thing. And again, just to go back to the picture of pain is gray, is if you can start learning how to relax your body and that has any degree of effect on the amount of pain that you're in, then maybe some of the other things that you've been told about your pain become a little less relevant because a lot of those things are disempowering.
Right. Yeah.
There's not a stretch to undo aging.
Right.
Yeah.
Oh, if only.
If only. And then we can talk about other things that can be unintentionally, but yet still provoking of more threat.
Yeah.
Like posture.
Right.
Or body mechanics. Or, these are, anyway, sometimes I can step on the toes of my profession.
No, I mean, I think it all comes together. I mean, so when I will talk about the guarding a lot of times, but usually when I'm talking about it from more of that like traditional outpatient realm, people, yes, they come in with pain, but a lot of times there are other things. It's not that they're a chronic pain patient usually. But we do talk a lot about, hey, okay, they come in with this experience of tightness. And a lot of times the way that I'm talking about tightness with them and their guarding is usually, at least in my realm, more due to weakness a lot of times. And in what I do with a lot of people is, okay, yes, we need to maybe mobilize this and not just stretch it to death, but how do we activate into certain arenas? How do we actually relax when that's the point? And then also strengthen to tell your body that, hey, actually, it's okay. Like, we can do this thing, and you don't have to grip onto my neck so hard and like get the tightest upper traps ever, because actually, if we strengthen the shoulder and we strengthen the back and we strengthen all of these other things, probably again, posture coming into that, it's huge, especially this day and age. Is okay, well, now we can actually give your body the resiliency to be able to do that on its own and not actually have to rely on this gripping response, essentially.
Yeah, I hear you and I agree. This is where we just don't have enough time. There's so many layers.
We could go so many rabbit holes.
Yeah, so many. So I think ultimately for me, it's not even so much about, because okay, I don't want to give misunderstanding about what I do or what I think is or isn't good. I mean, people can interpret things however they want, but I mean, it's not that I don't teach some stretching. I just don't prioritize it over other things. And even when someone does stretch and it feels good, it's like, hey, go for it. It's fine. But I think what matters more than what you do is why and how.
Yeah.
So this is a question I like to ask other clinicians, and this sometimes gets me into hot water. But when you have a patient or client and they are improving in whatever metrics you might use, whether it's pain or movement or strength or whatever, when things improve for a patient, whether you're a PT or a chiropractor or an acupuncturist or whatever you do, a body worker, to what degree, on a scale of 1 to 10,
Mm-hmm.
How confident are you that it's working, that the things that you're doing are helping for the reasons why you think?
Sorry, 1 second. It paused on me. I apologize for this. Okay, let me see where we were. I can go in and edit slightly of this, so. All right, we're just gonna start back. Can you hear?
Can we
What
hear?
is going on? Sorry.
No worries.
Let's see. I'm just gonna make sure I say this right now. Okay, can we hear? All right, are we back? No, not yet.
So there's some.
There's
What
something.
was that?
Where is it coming?
Testing, testing. Would it be helpful to open like a new file and then splice them somehow?
Let's see. It asked me where to use the input from. Where's? I love technology until it doesn't work. All right, can we hear anything now? Where is this coming from?
How about now? How about now? Does that have anything to do with it?
Did
Maybe
that
like click off
change?
and click on? Sometimes I just use the monkey wrench approach. Just
Yeah. Can we hear anything now? Hello?
Hello, can you hear me?
Can we hear anything?
Testing, testing, testing.
Meow. Oh, sorry.
Everything is broken.
Everything is broken. Ay, ay, ay. I'm gonna try. Maybe should I open up a new one and try it?
It's not a bad idea.
Because I could like.
Because it did this at the beginning and then you did something and then it started,
So
it wasn't and it was connected.
let me just unplug. Oh wait, here we go. Use. All right, can we hear anything now? Hello?
Yeah, I think it's working. Yeah, I told you.
Okay, cool. What the heck?
Bang it with a wrench
Yeah.
approach.
All right, let me pause this, and then we'll go back
Let's see what,
where we were.
yeah.
I wanna make sure that it's. I can't hear it. let's just. Where
Yeah, turn that off.
can we hear it in here? Yeah.
Is it coming through here?
Oh, here we go.
There we go.
Okay, I'm just gonna let it pause. I'm gonna like play it, and then when it gets to here, we can kind of pick up and.
You wanna, because I think there was like a little bit right there where
Yeah.
you were like trying to figure out the.
Okay, so it's just. Okay. Do you know where you are?
Yeah. So hopefully that makes sense why I would ask that, because the idea is a lot of the things that we do work for the reasons why we were trained to believe that they work. But the problem is sometimes things actually, most of the time, things work for reasons outside of what we were trained to understand.
Mm-hmm.
So whether it's I don't want to pick on professions.
Hey, you know, it's okay. We're here for an open conversation.
Yeah. One thing that I would not discourage somebody from getting or receiving in terms of treatment is a chiropractic adjustment if they fit the right criteria for it.
Right.
But what it's doing and what a person is told that it's doing is really important. So here's how I explain that. And this is evidence-based. I have receipts, so to speak.
Yeah.
But again, I'm not discouraging the act of adjusting, but I think we need to talk about what it's actually doing and what we say it's doing.
Yeah.
So what is often told, not always, because I mean, I will be just as quick to maybe criticize some physical therapy ideas that people are told. It's like, again, it's not the exercise, it's not the treatment, it's the explanation that can be problematic.
Right.
So the explanation behind chiropractic adjustments oftentimes is that you hurt because something is out of alignment or subluxed in some way, in some segment.
Right.
B, I will put that back in place for you through an adjustment. And C, you will feel better because it's back in place.
Mm-hmm.
So let's talk about what actually happens and why the belief in that explanation really is problematic, in my opinion. Number one, the association or correlation rather from the research between spinal alignment and the presence of pain is not there.
Yep, 100%.
So number one, there's no strong correlation. There's not even a weak, maybe just medium. There's a weak correlation at best between spinal alignment and subluxations. And this is actually I'm not inside of the chiropractic world, but there's actually a bit of a civil war inside of that world about that, because some schools have moved on from that, some schools have not moved on from that. So number one, no strong correlation between alignment and pain.
Yeah.
Number two, you can't put it back in place. So they've done research on MRI studies of people getting an adjustment and then getting an MRI before and after to actually measure the positioning and look at it, in a granular detail of where the segments are sitting pre and post. No change.
Yeah.
So number one, the alignment association with pain, not strong. Number two, you can't put it back in place. But number three, it does help a lot of people. The question is, if it's not being out of place, and you're not putting it back in place as the explanation, then what's actually happening? Well, the strongest piece of evidence that I can say is that we know for a fact that in many cases when you get a chiropractic adjustment, you release endorphins. And not many people realize, and I feel like this should come on the label of all opioids, all opioid medication.
Yeah.
You are taking a medication that your body can already produce. The word endorphin is a compound word for endogenous morphine. Endogenous means made on the inside.
I did not know that. That is so cool.
The reason
I love
why
learning.
the reason why opioids have a place to bind in
Yeah.
our nervous system is because we already have receptors.
Yeah.
Why do we have receptors for something that we take from the outside? Something that comes from the poppy plant,
Right.
opium.
Mm-hmm.
Why do we have receptors for that already?
Yeah.
Because we produce it.
Right.
Endorphins are endogenous opioids,
Yeah.
or endorphin.
Yeah.
So endogenous morphine. So anyways, that's one thing we do know happens when you get, oftentimes with chiropractic adjustments, is your
Right.
brain will release endorphins, which is a pain modulating thing.
Mm-hmm.
So then you do feel better, just not
Yeah.
because of the explanation. Why is the explanation problematic then? Well, number one, when you hurt next, which you will, what is your association? I'm out of place.
Right.
And when you're out of place, does that make you feel more safe or less safe?
Less
Less
safe.
safe.
100%.
You're
Yeah.
going to be more afraid to move, more afraid to engage in activity.
Mm-hmm.
And what does your brain do to areas of the body where it perceives vulnerability?
Cards.
It guards.
Yeah. Mm-hmm.
So I can go on and on. But
I know. I actually love this conversation so much.
but the same is true about posture,
Mhm.
or in some of the things that PTs might
Oh, for
promote.
sure.
Yeah. Or you're having.
I mean, I hear about the SI joint all the time.
Oh my! I was about to
Like-
say that.
In the PT world, I feel like the SI joint.
You have an upslip here and a counter nutation, or I don't even know all the language.
Yeah.
So the evidence for these things is just it's hard.
Yeah.
And again, the treatments are helpful. One of my favorite thinkers in this space, and depending on how far this podcast reaches, I mean, I don't know if he even wants me mentioning his name and associating himself with me, but a guy named Greg Lehman.
Okay.
I would highly recommend any professional coming to this podcast, any healthcare professional, PT, chiropractor, anybody interested in this field, go just listen to Greg Lehman's podcast interviews. He's amazing. But what was I saying about that right before? I'm sorry.
SI joints, PT world.
Oh yeah, what he says is like, you know, when you watch these treatments, or you're being trained in a specific school of thought, like a certain, like Maitland is a
Yeah.
popular form of manual therapy and physical therapy school, or,
Right,
or a sub-discipline that you can be trained in.
Mm-hmm.
It's more beneficial to you as a learning practitioner to just watch it on mute.
Yeah.
Let the explanations go, because the treatments are often very helpful, just
Yeah.
not for the reason why people are told.
Explaining it.
Exactly. And if the explanation then leads to more fear and threat, unnecessarily, because there's reasonable things to be afraid of,
Right.
but how how your alignment is, or how your posture is at
Yeah.
any given moment, like
Yeah.
okay, we keep talking about it. So
And I was like, I gotta sit up straight.
can we talk about posture for just a second?
Yeah, let's talk about
Okay,
it.
all right.
100%.
Now
Like, let's get into
now
it.
the pressure cooker starts. Okay, so show me a primate that sits straight, other than humans.
Yeah, there's not.
They must be in a lot of pain.
Yeah.
Yeah,
Mm.
yeah, man. I
Poor
bet
guys.
I bet those pain clinics for orangutans are just out the door full. It's like, okay, what am I saying here? So if you look at, and this is an interesting phenomenon. I haven't visited this in a while, but in some I think third world countries, you'll find these tribes and communities that are barely touched by a lot of more, the development. Yeah. And one thing that is of interest, and I can't remember if it was in South America or Africa, you'll find these communities that are barely touched by the outside world. They don't have chairs.
Mm-hmm.
They don't sit in chairs. And again, that doesn't make sitting is not the new smoking. I don't care what anybody tells you. I'll tell you why in a minute. But
I'm curious to hear your thoughts on that one.
the point is, when you see a person who doesn't sit in a chair bend down, they can spend a long duration of time in that deep squat position.
Right.
One of the things that people hear all the time, or at least maybe it's starting to change a bit more in physical therapy,
Mm-hmm.
is that you have to have a straight spine.
Right.
When you lift, when you bend, when
Yeah.
you pull, when you push, you have to keep a straight spine.
Mm-hmm.
Number one, it's impossible.
Yep.
It literally, if you squat and you keep a straight spine,
Mm-hmm.
it's literally impossible. If you were to actually measure lower spine, the lumbar flexion,
Mm-hmm.
it's happening. Even if you think you're straight, you're still not straight. You're still flexing, even if you are trying not to flex.
Mm-hmm.
So the reason why I say that isn't to say that it is or isn't good to try to keep a straight spine.
Right.
Or at least from a mechanical perspective,
Right.
it is or isn't best. I mean, there's evidence to say like when the load gets higher,
Mm-hmm.
a relatively stiffer, straighter spine is good.
Mm-hmm.
But if you're bending over to pick up your shoes off the ground,
Right.
you have my blessing to bend over with a rounded back. So why it's important is then, what does that then plant in the head of a person who lives with back pain? Is I have to always be in this position. I'll always have to be straight.
Right.
I have to pull my core in. I have to keep my back
Mhm.
straight and elevated. And that then creates more tension, more fear, more breath holding, and more pain. Not always, but often. And I can give you some other really cool examples of that. But before I do, I'm gonna give you a chance to respond because now we're in our shared territory.
Yeah.
So,
Yeah. Well,
thoughts on
so
that before I go?
I remember learning posture in PT school, and we did have like one of the professors was like, basically posture does not correlate to your pain experience or kind of same things with what we learned in MRIs. Like MRIs that show you have degenerative disc disease or slipped discs or whatever, quote unquote, that does not correlate to the experience of pain that you're having, right? So same kind of thing with posture. Now, do I think that people should have better posture? Yes, 100%, because we do live in a society that puts us into this like forward head, like we stay there though, which is a problem.
Text
it's like
neck.
not you text neck, exactly. Like the amount of kids these days that I see that they're like chest forward, head forward, and I just want to be like, oh, I want to push their shoulders back because that's what my mom did to me. And she would poke my shoulders back and poke my back and be like, sit up straight, Libby, she would always say this, you're gonna end up like your grandma. So anyway, sorry grandma, sorry mom. They're probably the only ones that are gonna listen to the podcast. But yeah. So I mean, I think that with posture, the problem with any posture is if you stay there too long, in my opinion, right? So if you're sitting for 8 hours a day, I just made this post on Facebook the other day, and it was saying that your employees are sitting longer than they sleep. So most people are not getting the full 8 hours of sleep, and most people are sitting for 8, 9, 10 hours a day doing whatever job that they're doing because we live in a technology-facing world, a lot of computer work, a lot of that forehead pressure. So you're staying in that posture for so long, and I think that's where the problems arise, because any structure or any posture that you stay in for a long time is not going to be great, just like you said with the fist, right? Like if you keep that posture, quote unquote, of a closed fist for a long period of time, it's not going to feel good. You're going to feel tired, you're going to feel sore. That could go for standing, that could go for sitting, that could go for a lot of things. Now, when I talk about posture with lifting, it's very much dependent on the person, where they are, what their load capacity is. So I end up talking about load capacity a lot with people. And so if you don't have the capacity in your tissues, in your muscles and your tendons to be able to do a certain movement repeatedly, potentially with load in a flex spine, then we're going to put you in a posture that's going to actually help you protect you right now until you can build that capacity. So it's always about, I think this is where when we start talking within any profession or just with anything, we start talking about, is this good or is this bad, or this does this or not does this or whatever, there's nuance to every single part of it, and for every person in a different given situation, there might be a different little piece of the puzzle that has to be added to actually see the full picture. And so that's where, when I talk, I don't tell people you have to be one certain way, because one, that's just not reasonable. like I sit for a lot of my job, honestly, and people, oh, you're so active. It's like, well, yeah, I go on a 2-hour run and I go to the gym for an hour or whatever my workout is for the day. But like the rest of the day, like maybe I'm just sitting on doing computer work or whatever it is. So, that's kind of where I try to educate people on the nuance, and I talk about capacity a lot with people. But having an understanding for people to understand that, hey, it's not inherently bad to bend over to pick up a pencil, but if you have chronic pain in a certain way, I'm going to show you a better biomechanical way to do that so you're not putting load on the spine right away. Because yes, maybe we do eventually want to load it, but right now your body doesn't have the capacity to do it in that way. So if you keep repeating flexion, then you're just gonna get worse. So maybe we actually have to keep an extension bias for right now.
For now.
So for now,
I love
and
that.
that's the key, right? For now. So I just had a client got in a motorcycle wreck, and not bad, he's good, but he did come in with, he's like, oh, my back is killing me. He's like, this happens, once or twice a year, and then I'm out for like 3 or 4 weeks. Like, what can we do? I'm like, well, I'm not gonna guarantee, because normally it lasts a month. Like, I'm not gonna guarantee that we can do anything crazy. But he was like, yeah, I feel like I need to stretch out my back. I just like, he kept bending forward, and I was like, do you feel better with that? No, it keeps getting worse. Okay, well, let's go the opposite direction. So I literally just had him in propped prone for 30 minutes out of our hour-long session, and guess what? 75% better the next day. 3 or 4 days later, I told him, I was like, just keep doing this, like, extension, we're doing extension, and avoid the flexion for now. He's like, that's the quickest my back pain's ever gone away. He was back on the motorcycle the next weekend.
Love it.
So, like, those types of things are important to understand for people, that there is so much nuance. And I think that, I'm kind of going on a tangent here, but for people who are listening to health information or absorbing information on whatever social media platform it is, understand that there are going to be clickbait 30-second things that you're going to watch, and potentially there's a good piece of information in there, and a lot of times it is, but there's a lot of context missing around that particular piece of information, and also the context that you're then applying that piece of information into your own life. And so that's where all of these types of discussions, I love hearing from you and your perspective and everything, but then being able to say, okay, yes, and.
Yes, and.
Yes, and.
Yep.
And there always is more to the story than a lot of times, the cover of that book, basically.
That's right. It's great.
Yeah.
It's a great picture. So, yeah, depending on what direction you want to go with the conversation, because this isn't an interview, it's a conversation.
No, it's a conversation.
I love that. There are so many things that I could just rattle off about this topic of posture that I think are just, it's not so much myth busting, but it's just reconceptualizing or reframing some of the things that people often hear that I think can unintentionally cause more unnecessary fear and misunderstanding on the part of the patient, on the part of the person suffering. So number one, let's give credit where credit's due. I think that there's a lot of good reasons for a more upright posture. And when we say posture, really what we're saying is how you're holding a body part. It's not like just about your trunk.
There's not one visual, posture could be anything. Like in yoga, you have yoga postures, right? They're all different postures.
I just think about it as posture means how you're holding your body.
Yep.
You can sit straight and be guarded and tense, and you can also sit straight and be relaxed. That's something I've learned through my meditation practices. You can have an erect spine and not be rigidly holding yourself up.
Right.
You can learn to relax into that stacked posture. So when we say posture, what we're saying is how you're holding your body. But when we say it, we're often alluding to the idea that you should be sitting straighter.
Yeah.
Now, psychologically, there's good reasons for that.
Right.
If you sit straighter, generally, like they've done research on this, you might be familiar with it. Like if you stand like Superman for a certain amount of time.
Power posing. Yeah.
your brain chemistry starts to change, and your emotional, your affect, your height, your mood will literally change, even if you weren't trying to make it change. Even if you were just like totally blinded to why you were being asked to stand in that position for however many minutes.
Right.
You'll start feeling different. And there's something about what that signals to our brain when we stand or move and hold our bodies in certain ways. And if you're sitting more upright, the signal that your brain is getting is that you're confident, you're proud, you're in your body and you feel present. So that's a good reason to sit more upright.
Definitely.
Unless it's making you hurt more.
True.
Number two is socially, on the other side of that equation, people will approach you if you seem more confident.
Right.
Which makes you more likely to get new connections or create more sense of community and belongingness. These are really important things for well-being and health. So those are good reasons. Then you can make the argument about like lung function. Your lungs can expand better when you're more upright. And then again, going back to specific scenarios when you're lifting heavy or you're doing some certain kind of explosive movements, posture matters more and more and more. But in most cases, it doesn't matter as much as is often prescribed or is emphasized.
Yeah.
So that's one thing, credit where credit's due. But I think the issue that I have mostly, because there's this expression that I like, that back pain is the is the common cold of the musculoskeletal system, which is another way of saying that we all get back pain at some point. In the most common source or common area in the body where chronic pain exists is back pain. So one of our profession's contribution, I believe, to a lot of the persistent back pain in the world is the perception of a weak core. Now, I'm not saying that there's no relevance, but it's the perception. It's the interpretation on the part of the patient about their core. And here's what I mean. A lot of the core strengthening research started back in like the early 90s. I think a lot of it's attributed to Paul Hodges. And the idea was, or what was determined, is that for people who had persistent back pain compared to those who didn't, there was a delay in firing of a very specific muscle. Probably know what it is, the transverse abdominis.
I was gonna say TA.
TA. But that delay in firing was like hundredths of a second, I believe. It was very, very small. But from that, a whole industry was created. So the perception, the interpretation, which still exists, and there's enough evidence, and I can point to a couple of research, but the idea is, if you look at it as a cause and effect sort of perspective, from a PT perspective, is you're having back pain because your spine isn't stable enough on its own, and your transverse abdominis, and maybe some other muscle groups, aren't pitching in to stabilize that spine of yours that's so fragile and like a stack of dishes ready to fall over. It's like, that's the perception.
Right.
To kind of characterize it a little bit. So then, all these stabilizing exercises are then born. But here's the idea, or here's what's been challenged about that. And there's some other people who are way more knowledgeable and have been doing this for a lot longer and are evidence-based. People like Peter O'Sullivan, another really great practitioner. Yeah, he used to be like a really world-renowned, I think, manual therapist. But he, like others, have shifted away from some of the training and perceptions that he once had, that he learned, to a more modern evidence-based approach. And one of the things that he likes to point out is, if that idea is true, that you have back pain because you're not stabilizing your spine well enough, then you would expect the following. If you take two groups of people, one group that has back pain when they bend forward, and a group that doesn't have back pain when they bend forward, and then you were to measure intra-abdominal pressure, as in the amount of pressure that's created in the abdomen by the surrounding musculature. So the idea here is, if you have back pain, you'd expect, if this idea is true about stabilizing the spine, if you have back pain, you'd expect there to be less intra-abdominal pressure because those core muscles aren't tightening up at the right time. And you'd expect the opposite to be true for the people who don't have back pain. That when they bend forward, they have higher intra-abdominal pressure. You want to know what they found?
The reverse.
Opposite. The people who didn't have back pain didn't tense more. They didn't co-contract their abdominal muscles, which are flexion muscles of the spine, and lumbar paraspinal muscles, which are extensors of the spine. They didn't co-contract. That's what the fist really represents, is a co-contraction of muscle groups that are antagonists to each other. So one example is like with the elbow, your biceps flexes your spine, your triceps extends your spine. If both of them
That's fine.
your elbow. I am a physical therapist with a license, I promise.
I love it.
So
I knew exactly what you're talking about.
but if your biceps and your triceps contracted at the same time, your elbow wouldn't move, because it's a co-contraction. Well, so that's what happens when you teach somebody that you have to brace your core. So the idea ends up being that, or the result of the study ends up coming out that when those who bend forward they have lower intra-abdominal pressure, but those who have back pain when they bend forward have higher intra-abdominal pressure. What that means is they're co-contracting and stiffening their spine, and to kind of just just move forward with the conversation,
Yeah.
what's upstream of that is ultimately fear.
Okay.
And it's not always conscious.
Do you want to use audio device? No, I don't. I don't think I want to change it. Hello. And now it's gonna. Oh, wait a second.
All right, we'll pick up from here.
All right. Hold on a second. Should I? Well, I can cut. Can I cut this part out? Or
Yeah.
should I?
I think you can cut it.
Okay.
If not, it'll just be a really awkward pause. Maybe you can play some music overlay.
Yeah, we're like.
A moment later. So.
Co-contraction.
Yeah, so co-contraction. So the idea there, and this is just one of many, is that you have to keep your spine straight and stiff all the time by pulling in your belly, which also makes you hold your breath, which isn't helpful either.
Yeah.
And it's all often, not always, well, it is kind of always, it's fear-based. And one last point about that is that, and there's more we can talk about, or that I can talk about. Obviously,
Yeah.
I don't have any strong opinions about this at all, right?
No, not at all.
But the idea though is with fear, that is, if I asked you to hold your breath and you did so, and you did it as long as you possibly could, eventually, before you take your next inhalation, there's going to be a period of time. If you just try to stretch it out as long as possible, you're going to start feeling a little anxious.
Yep.
You're going to feel anxious, which is a derivative of fear, right?
Right.
Does that anxiety represent a conscious interpretation that you're never going to get a breath in or that you're underwater? No. You're going to start feeling anxious, but not because you're literally afraid that you can't breathe. You're doing some exercise of holding your breath. So that's what I would call unconscious fear or physiologic fear.
Right.
So what I'm not saying is that people who have back pain are just afraid to hurt. In fact, it's usually not the case. They're not afraid to hurt. A lot of times they're afraid to stop doing the things that they're doing, so they keep pushing into the pain.
Yeah.
But the point is, unconsciously, or on the sense of the nervous system, and I also like to point out the fact that it's called the nervous system.
Yeah,
right?
nervous. Yeah.
It runs on fear. So when there's more nervousness about your spine in the nervous system, what's going to happen? It's going to keep it more sensitive, keep it more guarded.
Yeah.
So these are just a couple of ideas that I like to share with folks who are interested. And again, it just highlights going all the way back to pain is gray.
Yeah.
And what people believe about their pain really, really matters, because it then ultimately can be either empowering and lead to more confidence in their body, not because you're thinking happy thoughts and that you're adding something that's not true into the picture. We're just maybe taking a second look at some of the beliefs that you've been given or that you've come to just on your own that might be causing more unnecessary fear and threat around the safety and stability of whatever body part that hurts.
Yeah, I think it's really interesting to hear your take on it, because I do teach a lot of core stability, and not just for back pain, but in the strength training that I'm doing with people. And there is this, I was listening to a podcast yesterday or earlier this morning, something, on Huberman Lab, and he was interviewing a physical therapist, and they were talking about essentially, like, you might do kind of just how treatments, we kind of have this toolbox, we've got five things in our bag of tricks, and you might throw, those 5 things at 90% of people, but there's going to be this additional 10% where that's not going to work for them. And I think in this particular, the way that I'm kind of absorbing what you're telling me and integrating how I think about things into it as well, is the fact that especially when there's really chronic pain, like acute pain versus chronic pain, and yes, there's components that are both going in, but like there's crossover, right? But especially when somebody's been trying to doing all of the core work, like they said, my core is weak, and like I've been doing core work for 6 months and my back still hurts. Okay, well obviously that's not working, right? So there's something else that is going on, and we need to approach it from a different way, and probably the opposite of what you've been doing, if that's made it worse or not helped at all.
Right.
So I think that it's like super interesting to hear that in the study. That was like really interesting to me because it does make sense too. Is these people that are guarding, and that's gonna create even more tension and fear and all of the psychological components that also feed into the hormones and signals and everything that are then increasing, like what we've talked about from cortisol levels and the sensitivity and all of that contributing to increase that pain experience for certain people. And then it's just a very interesting realm because there's so much to pain experience. What we've talked about has just like run the gamut, and I know that there's so many, like we've only literally like pinky scratched the surface. There's so much more to talk about in this arena, but I mean, I have learned so much from just having this conversation from you. Honestly, I think it's so cool because, and also I love when people, physical therapists especially, and or just people in general, challenge what I have either been taught or kind of my current thinking, because a lot of times I try to learn more through continuing education or courses or the podcast that I'm listening to, but there's only so many hours in the day, right? So, which is one of the reasons why I wanted to start this podcast, is to learn from people and be challenged on the things that I'm doing and hopefully provide me with more tools to also say, hey, like, actually there's this thing. And if we really have chronic pain that we're dealing with on a certain level, like, you have to go see Jason, because that's not necessarily that's not my expertise, even though I can now have more ability to educate people on certain things. And I think that, yeah, there is just so much. I honestly want to do a follow-up podcast with you, because I think we dove into so much of the background on all of this information, and I think it lays a foundational framework for people's understanding of what pain actually is, the misconceptions around it, kind of unpacking a lot of those misnomers that people might have around pain, and then I would love to do another follow-up episode where we talk more about some of the action things, because I know that we've talked about that also, like the ways that you work with patients, and we've talked about, I want to dive more into your meditation work and all of, there's so many fun things to dive into. So I think it would be really cool to do a follow-up episode where we dove into some more of those action items and things that influence your practice in that way, because yeah, it's just the beginning.
Yeah, painful conversations with Jason. Conversations with Jason about pain.
Okay, yeah, wait a second.
Or maybe not.
Yeah.
Can I just leave like with just a couple?
Yes, let's do it.
Quick notes. Okay. Number one, when you said earlier about having like these go-to exercises, keep doing. Like the idea here isn't to just totally.
So you're like rewriting the entire system.
We're not rewriting the system. It's just maybe thinking a little bit more clearly. Again, going back to that question, how confident are you that when it does work, and that gentleman who had a motorcycle accident,
right,
did his core stability cause his spine to be more stable or something? And it might be part of it, for sure. I'm not saying it's not part of it, but it might have been just the right thing to help him feel confident that he can recover.
Right.
So there's the placebo effect. The placebo effect is a real thing. It's like if you give two people a blood pressure pill, both of them a real blood pressure pill. So people think placebo, sugar pills, like not the same thing. If you give two people a blood pressure pill, but you tell one of them that it isn't a blood pressure pill, they've actually shown research that the person who believes it's a blood pressure pill, it's actually more effective.
But they're both getting the same medication. It's
the same medication. So what you believe about your treatment, even if it is helpful in some ways, matters. So it is important that what we say to folks, that we have the responsibility as providers to be scrutinizing to our own perspective, 100%. To make sure that what we're doing isn't just evidence-based, but it's also logical and makes it will make sense to the patient.
Yeah.
But number two is what I'm sharing them with this person and explaining to them about why what we're doing is going to be helpful, creating more empowerment or more disempowerment. Is it creating more fear or more safety, more hope or more? I mean, I guess it is kind of always hope. It's like, well, even if your pain is because of your core instability, the hope is you can just keep your belly tight all the time, or you do all these core strengthening exercises. So again, it's not so much that the exercises aren't helpful or the movements aren't helpful.
Mm-hmm.
It's that the explanations for them can either be more empowering or more disempowering.
Yeah.
And then we as clinicians need to be thinking through like what we're actually, what else could explain the benefit that this person is experiencing.
Right.
And then one other thought about this, because there's actually a lot more thoughts.
So many thoughts.
But one is, I think I heard this first from Greg Langman, but I think it's the idea of like movement homeopathy.
Okay.
So I'm not a homeopathic practitioner, well maybe I am now, but the point is, homeopathy, my best understanding, okay, I'm going to be skewered by people who are more proficient in this area, that if you're allergic to something, for example, you slowly take the thing to build up a tolerance in your system.
Get immunity kind of.
Yeah. And I think, I'm not sure, I think that like allergy shots is a form of homeopathy.
Yeah, for sure.
You're introducing the thing that you're allergic to, but in a
little by little,
in a very systematic way, right? Movement homeopathy is the same thing.
Yeah.
It's like, okay, you want to be able to bend over and plant a garden? Well, guess what we're going to be doing? We're going to be working on bending over more. So you do the thing slowly over time, but that's after you've calmed the system down first.
Right.
So when you calm things down, understand a bit better what's happening in your body, learn how to work with it and be a better partner and understand it. But then slowly reintroduce the thing that you're wanting, but in a way that doesn't, as I like to say, wake the bear. There's my other favorite metaphors. You can poke the bear, just don't wake them up.
Yeah.
So yeah, there's so much that we can talk about, but
I think that's a great point too, because people then do become scared of doing certain movement patterns. I mean, I hear this, say, in the lifting world or like kind of outpatient, quote unquote, more like your traditional outpatient stuff. Like, oh, well, like I can't deadlift. I just can't deadlift. Well, my doctor said I can't deadlift. My back's bad. Can't deadlift. Like, did you pick up your box from the ground the other day that you got from Amazon? Because you did a deadlift. And it's like, okay, explaining to people a bit more about how to do these, how these movement patterns are functional, and that we do have to bend over. We have to do those things, and we should be able to do those things. And giving people the empowering them in it and saying, okay, we don't have to touch our toes right away, but we're gonna little by little, you said, I love that. Yeah, I love that. I definitely integrate that, but I don't think I had the word for it, is to like just little by little adding in those movement patterns. Titration of different movement patterns. And so, I think that is so cool. And it's also very interesting because kind of within all of this, again, I always come back to this, but the way that things are explained to somebody, you might tell one person and explain it a certain way and it's going to empower them, and it might make somebody else feel completely defeated. So I think that there's an interesting, we have our own experiences that we're like, well, this would make me feel good, or this is the way that I would want it to be explained to me. But there's always this dynamic conversation, engagement going on with the person that you're helping, whether it's a patient, client, your neighbor, parent, whatever, and understanding, learning more about them, and then understanding them as a human. And like you said, the one woman who loves to have the explanation, like perfect, that's a great way for her to be educated about how to best serve her body and best recover. Other people, like we talked about before, not so great. Yeah. That might make them feel completely defeated. Well, I don't understand any of this, and it's like, that's gonna make them feel really defeated. So I think that from a clinician standpoint, it's really important to understand the people that you're working with on a very human level, and allowing that to help dictate the way that you are then explaining and or providing your service to them. Because it's all so nuanced, and that's where I wish we could take healthcare and make it just magically snap a finger and say everybody gets super individualized care and everybody is understood as their own human bucket. But unfortunately, that's not the case. Maybe one day. But we're doing our little piece here to do that.
Absolutely. Yeah. This has been such a good conversation. I feel like there's so many loose ends that I hope.
We're gonna do part 2. We're gonna put it on the schedule. Good. We're gonna do part 2 because honestly, I really do think that this is such an important not only important conversation, informational conversation. Like I said before, I love to learn, and so I think I'm learning so much, and I love the ability to have a conversation between like two practitioners, and also where I'm coming from is slightly different from you, right? So it's so interesting to be able to have that and put it in the context of where we kind of are within our fields. So thank you so much for being here today, Jason. I am like so stoked that this is the first podcast, official podcast. We kind of did a dry run, but the first official podcast for the Human Health Collective, and like as part of the collective of humans who are focused on whole human health. I am so appreciative of everything that you do for the community, for the people that you serve. So yeah, super, super thankful.
And I'm very grateful thank you for saying that, and I'm very grateful for you, Libby, in so many different ways. I love what you're doing, love what you're putting out there. You're an inspiration to me and many other people, both as professionals, but also, the public. So
yeah. Well, we're just going to keep this conversation going. So in the meantime, I'm going to come up with the ending tagline at some point, but I think all that I have is go move your body today, because that's important. So, all right, guys, we'll catch you on the next one.
Well,
that
move
was
your
so
body
good. Like, I'm going to come up with something better probably, but we're going to just make it.
You've got stuff.
Oh, is it the black stuff?
Yeah.
Head, hair, yeah. I was like,
one on your neck.
I'm gonna be shedding these little pieces of plastic.
Yeah, maybe you talk to Common House.
Yeah, I was gonna say,
Get your shit together.
I was like, maybe I should get some headphones, but maybe I should just ask them if they should buy some more headphones for us.
Okay.
We're almost there, but I think save. Perfect. And then we just have that one little spot to cut out, but that was really good. I'm excited about that.
You are?
Yeah, that was super good. I love the fact, I feel like you were so much more comfortable this time too. Just like, I like the idea of it just being a conversation and talking. Because it feels much more chill. That's why I didn't want to, like, Adam asked me, she's like, what should we, like, is there anything you want me to prepare or whatever? I was like, no. Because when we sat here and just had a conversation, it was great. It was like free flowing. You're going to talk about the things that you're passionate about, the things that you actually want to talk about. And it's gonna be great, because those are the types of conversations that I wish, starting last year when I was talking to people about the Health Collective and everything. I was like, I wish I would have recorded that. That was such a cool conversation,
Yeah.
So that's kind of what my goal is with these ones. But I really do want to do a follow up and like touch more, because then I was like, I wanted to ask him about the suffering thing and like how I thought about it, because I wanted to say something on that too. And so there's so many components.
We can have a little.
We can have a mini series. Yeah. 100%. Oh, and then I can be like with our, friend of the podcast.
Friend of the podcast. I love that.
You know how podcasts say that?
Yes.
It's friend of the pod.
Yeah. Welcome back.
Welcome back.
Absolutely.
I love it. So yeah. I'm gonna
meet them downstairs.
Yeah, let's go meet them downstairs. I need to pause this.
Oh yeah, meeting stuff.